Dear colleagues, I would like to share with you two cases of topography guided CAIRS customization for superior visual outcome. In this case, the patient has the thinnest cornea of 357 microns. And as you can see, the patient has significant steepening, centrally Kmax 60.4. His inferior nasal steepening is 52.1, whereas his superior temporal steepening is 46.6. As you can observe in my surgical plan drawing, I will need to shorten the segment and thin out the segment superior temporally, because I do not want excessive flattening superior temporally, whereas I want maximum flattening inferior nasally. And this is exactly what I did. So after fashioning the tunnel and opening that nasal incision, I went ahead and I shortened that CAIRS segment so that it fits my pre-placed marks on the cornea. I don't want it to over flatten elsewhere. Then I shorten. So I first start by shortening the segment, and after doing so, I will go to the superior temporal part, which is less steep than the inferior nasal part, and I will try to cut part of that tail to half its thickness. So hopefully, post-operatively, the corneal surface will rebalance according to what I have customized. Here I'm also almost done thinning out that superior temporal part. And then after doing so, I will grab that segment and I will plant it into my tunnel. Here I place the segment from the main temporal incision. Then with the inverse sense key, I will spread out the segment till it reaches my pre-placed mark. And that concludes the procedure. Post-operatively, the patient's visual acuity jumped from counting finger near phase to 20/40 minus because of this customization. Moving on to case number 2. The thinnest cornea for this case is 448 microns, and the patient has a Kmax of 60.6 diopters. As you can observe, the catectasia has taken a snowman pattern, and for this reason, the segments were customized according to this pattern. As you can see, I used half a segment at the head because the Kmax is 49.7, and a full segment below because the belly has a Kmax of 60.6 microns. Then I made my 7 usual marks, marking the visual axis, both incision sites, and where both segments start and where both segments end. Patient's visual acuity jumped from 2400 to 2030 unaided. His best corrected visual acuity improved to 2025 with a minimal sphere and minimal astigmatism. So in conclusion, personalizing CAIRS segment selection using detailed topographic data offers a clear pathway to superior visual outcomes. I anticipate that the next generation nomograms derived from this individualized approach will markedly advance the efficacy of CAIRS.